Okay, guys, day 2, last day of chapter 19. We're not going to get into 20 today. Just not going to happen. I'm going to try to get ahead of schedule a little bit. Maybe do a couple of videos over the weekend. I mean, obviously, it's a few days away, but once I get to the weekend, I should be able to get us a little bit ahead of schedule. Once again, I don't have a lot of time this morning. I had to run off. So we actually left off Bezors. That's a hard one. And I got a picture for that. Oh, it's not very good. And I brought up a picture here for the pyloric stenosis that I just wanted to show you some things. If we were to measure this is obviously pyloric stenosis here. This is a very thick muscle. Well, it certainly seems like pyloric stenosis. I mean, I guess you could be in the room and suddenly find it to be dynamic. If it's dynamic, it's moving, it's opening, and then it's not pyloric stenosis, but it certainly looks like it. I just measured the wall thickness here, or pretended to, and if it's greater than 4 millimeters, that is a problem. And then the channel length, right about here to right about there. That's a little bit of a little fuzzy at either end on how you measure it. But if it's greater than 1.6, that is a mistake. Greater than 1.6 centimeters. I made a mistake last time. I apologize. 1.6 centimeters on the channel length. Oh, that's right. I'm going to pause recording here. Where's my pause? Hold on. Okay, I just wanted to double check on what we're looking at with this image here, because that wasn't entirely clear to me what these arrows are pointing to. And apparently what it is the mucosa is being almost squeezed out of the channel because of these large muscles and the squeezing. So it's actually being squeezed out a little bit. I'll be honest with you, I don't really fully understand what they're talking about here. All right, let's just make sure we are sharing our correct screen. I'm not so sure I was sharing the screen a minute ago, so let me say this again. I was checking on this image right here and trying to understand what these arrows are pointing to. Apparently, this is like mucosa being pushed out of the channel here. Here's the channel. Here's the muscle and muscle there. And apparently that's some sign. And like you've already heard me say, I'm not 100% sure of really what I'm looking at there, but I would have to research that some more. Sorry, I didn't do that before. Bezor, I grabbed an image. You could look up Bezor pediatric ultrasound, and this is almost the only picture you get. This is a type of phyto. No, this was a hair Bezor. In fact, there's a surgery image that goes with this. It's pretty remarkable. A hairball the size of oh gosh, almost a 2-liter bottle was being pulled out of the. It had to be open surgery. But anyway, I just wanted to grab a picture, and this actually indicates to us that ultrasound is the absolute worst modality to look for one of those. But that's okay. We still need to know them, even though when we go to look at them, we're not going to see much. You know, we see something huge in this young girl's stomach. It was a 12-year-old girl who had a bad habit of chewing on her hair. Okay, so new stuff here. malrotation of the gut. Oh, that's right. I've got a video. So, and it's a short video, like 2 minutes. Arrested development of rotation. So our gut rotates in stages around. As we're developing, early in development, it rotates. It actually rotates, let's see, 270 degrees. So more than 180 degrees, it goes around and around. And it actually almost corkscrews back in. And the key to this is that in the middle of the corkscrew, and you'll see this in the video, dead center in that corkscrew is the future superior mesenteric artery. And so it's really interesting as we scan through the body, the SMA, that's just kind of why it is an anterior and stays anterior to the abdominal aorta for so long, is because everything's going around it. And that's normal going around. But the vessels, the SMV is in there as well. That's not spinning around, but the intestines kind of do a little spin. And I'll show you the video in just 2 seconds. But if we're looking for any kind of malrotation of the gut, we are going to scan through in transverse, usually superior to inferior, because that's just standard. There's no reason why you couldn't go inferior to superior. But in transverse, we're going to look at the SMV and the SMA. Are they parallel? Do they twist? In other words, is there a whirlpool sign? So the vessels shouldn't twist. These two vessels anyway, they shouldn't twist around each other. But if they do, you get a whirlpool sign with color. Are they reversed? Is the SMA to the patient's right versus the SMV? The term volvulus, that really refers to, it's a malrotation, but it refers to a bowel twisting on itself, causing obstruction, possibly causing vascular compromise as well. So that could be a big problem there. I have some images we'll look at first. Dang it. There we go. Let's look at normal anatomy. Remind ourselves of normal anatomy. By the way, guys, I've asked a number of you, and everyone's failed the test. That's okay. I know it's a lot. It's a lot of three-dimensional things to worry about. I'm not upset. I don't want red. I want blue here. This is just an add-on. Remember what goes like that? Left renal vein. Kidneys down here towards our back. The renal vein comes up in between the SMA and the aorta and into the IVC. It's usually hard to see, but that's what that is. The other thing that goes between these two is the duodenum. So that's something, you usually don't see the duodenum. It's not that clear, but it's there. So that's just something else to think about. Okay, but that's neither here nor there. We're going to look at normal. Let's get rid of my little. All right, normal anatomy, SMV, or we could also, at this point, this is really the confluence, but the SMV is coming in from our perspective, just like the SMA. If you point at the screen, that's the perspective that we're looking at. It's coming out from us on the screen as well as the SMA, and they are parallel. The SMA is more or less above the aorta, and it is to the patient's left, not our left as we're looking at it, but the patient's left to the SMV. In other words, the SMV is to the right of the SMA. This is normal anatomy. And of course, there's going to be some variation. You don't have to worry about it. The SMA is a little bit over here or a little bit over here. what do we got here? Ah, okay, all right. We've got the same picture really. There's our aorta here, IVC with that vessel across. The SMA, it's actually a really horrible picture, but that's okay. And I often say the confluence, but really it's SMV right here. We're going to have a vessel coming down here, going to the spleen. That's the splenic vein coming up to the confluence. And then coming from our perspective straight down into the screen is the SMV, SMV, and SMA are parallel. And you can see that here. This is a totally different perspective. SMV, SMA, they're running straight up and down the body. It's inferior to superior or vice versa. And of course, on this picture, our transducer is, well, it's all the way up here, but it's transverse, slightly oblique, but transverse, and that's why we're getting a transverse view over here. Okay, let's move down to something a little more abnormal. Here's just slightly abnormal. This would be, you know, you might not catch this. Because look at this, here's our aorta, and here's our SMA. Our SMA is pretty much where it's supposed to be, you know, more or less above the aorta. I guess this is IVC. If that's the IVC, it's lifted. IVC should be more like down here, you know, gravity is not gonna wanna float up there, so it's almost lifted, but then again, I'm not 100% sure that is the IVC, so let's stay quiet about that. But here's our SMV over here. So it appears to me almost like the SMV and pancreas probably have been pulled this way more than this guy's been pulled that way. But I'm not 100% sure. But something's going on. These are not right. The SMV is now to the patient's right versus the SMA is to the patient's right versus the SMV. Just for perspective, let me draw in uncinate process. Couldn't remember that name yesterday. And ooh, let's see. That's actually goes this way, and then I kind of lose it. I don't really know exactly what I'm looking at on that, but there's the head of the pancreas, kind of the neck, body, and things start getting a little funny over here. Well, maybe that's because of a weird anatomy. Here's a color image of that SMA over here, SMV over here. Those are a little bit reversed. And over here, and so this is just a little bit reversed. No whirlpool sign. Here, this is full on volvulus whirlpool sign. And let's see, what's the arrow pointing to? Probably the SMA, but we have vessels going kind of around in a circle, and that's not normal there. And certainly on this image, we see there seems to be some kind of twist going on. You can see there's a little twisting motion there. Okay. Oh, that's right. This was actually the SMA, which appears absolutely tiny. I'm not sure why it would be so small, and that's the SMV. But beyond their malpositions, everything is just really twisted. Oh, and a little bit of obstruction here. And on the barium study, this was supposed to be, oh, yeah, look at this. Duodenum. Doing a little twisty here, and so little extra filled here because, well, it doesn't like to go through this twist, and some fluid's getting through, so that's good. But yeah, okay. Malrotation of the gut and volvulus, kind of more or less the same thing. Intussusception, this is a fun one. I remember the first time I found one of these, it was so cool because you know what actually happened when the first time I found one of these. Let me move my little picture. So, okay, never mind. It's not working. Oh, I know why. I can't lay this pen on the pad and then try to use the mouse. It's fighting each other. That's okay. So the first time I found this, they were like, well, you know, this baby's, well, it's colicky, you know, so a very, very colicky baby. Let's look at these first. Colicky, probably had some bloody stool, vomiting, and the doctor might have pushed down and felt an abdominal mass. So those are some of the symptoms we could see with intussusception. And this is the #1 cause of obstruction in early childhood. And, yeah, we're talking pretty early. You know? Well, in fact, it occurs mostly in 3 months to 3 years. So anyways, I keep saying the first time I found it, I looked at first, I saw absolutely nothing. And then I pushed and the gas just slid to the side and suddenly, like right from the textbook. And I instantly knew what I was looking at. So that was fun. You know, you get to know that, textbook, and you remember what those pictures look like. And I could somehow remember them even without an internal eye. And you see it out there in the field, and it's like, I know what that is. So intussusception, well, what is it? It is a telescoping of one section of bowel into another. Kind of like, I don't know, pulling a sock on. I'm trying to think of a good analogy. 90% of them are ileocolic. Well, think about how this appears. If we were to, let's draw a picture of an ileocolic section here. I'll quickly do this. Let's see. Here's my. This is my large intestine here. This is the ascending large intestine, very beginning of our intestines. It'll also have, I'll just draw a little right there. Not 100% sure why we have it, but that's the appendix. And then let's change my color a little bit just to show a difference here. Then we have another section of bowel coming in to it. That's the ileum, comes in right there. And there's a huge size difference. Well, you can imagine this is why 90% of intussusceptions occur here. And so what would happen, let's go back to black. What would happen with an ileocolic is that this section, maybe a few inches, just goes, swoop, gets sucked in. The ileum gets sucked into the colon. And obviously with the size difference, that's why most of them occur there. But they can also be ileo-ileal. I feel drunk when I say that. Ileo-ileal. Anyway, that is a possibility, and that's just the ileum going into the ileum. Or colic, or Coca-Cola. Colic is just a part of the colon going into another part of the colon, but those are less common. So we said occurs mostly in 3 months to 3 years. Colicky, bloody stool, vomiting, abdominal mass. Older children are more likely, if they are older, 4, 5, 6 years old, and they have this, is usually a lead point. I know it's the same way to spell lead. Anyway, lead point, and that means that there's a mass of some sort. It could be lymphadenopathy, and it could be Meckel's diverticulum, which we'll talk about in a second. But something's heavy and almost pulling it in. So that's a possibility there. The book mentions hydrostatic reduction. Ooh, that sounds crazy. All that means is a kid gets an enema. Well, most of the time when we find this, they get an enema and that cures it. And like cures it. They'll never get, well, hopefully never get it again. It's just, you know, bad luck that they got it and good luck that all it takes is an enema to fix it. If it's really bad, surgery is necessary because these can, if they're sitting there long enough, they can cause, obviously obstruction, but they can cause vascular compromise as well, which would, well, kill part of the intestines. On ultrasound, we get, in transverse, we get a target sign. In other words, target sign meaning, let's say we have a colon, and then the colon's folded back on itself, so colon, colon, ileum, and that's folded back on itself. It doesn't just slide in without causing problems, so ileum, ileum. So you end up getting these multiple wall layers and create this target sign, which is kind of what we're seeing here. In sagittal, it's pseudokidney. Well, I don't know, it doesn't look like much like a kidney, but in sagittal, it's going to be kind of the same type of deal there. Let's go to a couple of good pictures here. Oh, and not only is, so let's look at the cartoon picture here first. So we have our colon and our ileum going in, and that ileum, everything's folded back on itself. So we have wall, 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 wall. But look what this yellow is. That yellow is mesentery. Mesentery actually gets pulled in because mesentery is all over the place, holding everything in together, supposedly keeping this from happening. So mesentery gets pulled in as well. Remember, mesentery is double folds of peritoneum, basically. Mesentery, that is where we find our blood vessels are inside of mesentery. Our lymph nodes, many of our lymph nodes are inside of mesentery. So this person has a, this is very large, so we have a colon here with probably ileum. Well, they're showing that yeah, so it's probably ileum. It's in here, and well, we have a lymph node got pulled in, and I would, oh, okay, another lymph node here. They're saying, what's this? This almost looks like an artery over here. I don't know that it's an artery, but gosh, it looks like one to me. Inverting limb, everting limb, inverting limb. Ah, okay, well, like I said, it doesn't just simply slide in. There is a folding. Oh, they color coded it. Here we go. Purple is the purple is actually how are we going to say that? That's the, well, I don't know how to say it other than saying that's the everting limb, and then it folds around. And you have another limb, another wall. But it's really it's all one wall. It's just one's folded back like this, and that's called the inverting limb. So yikes when we have that. Crohn's disease, we kind of mentioned this before in abdomen earlier, once upon a time. God, does that feel like years ago? Crohn's disease, this is something that obviously adults have, but I figured I'd just go ahead and mention it again because it's not really well, it's not an ultrasound thing, not primarily an ultrasound thing, but it is an inflammatory bowel, sometimes idiopathic, probably autoimmune disease. If children do get it, they're probably older than 10 years. Usually the terminal ileum proximal colon, if you want to, what's the terminal ileum proximal colon? That's the terminal ileum proximal colon. So this is a real problem spot, isn't it? Terminal ileum, this is ileum over here. Ili. Ili is over here, and proximal colon is here, and here's our appendix down here. By the way, guys, when you see the term cecum, anyway, cecum and appendix here. Okay. So when we do see Crohn's disease, it could have an appearance somewhat like this: hypoechoic thickened walls. Not throughout the entire intestines, only one section. So you find you suddenly come across a section that looks like this and everything else looks normal, very high chance that that is Crohn's. I think what they're trying to indicate here is reactionary fat. This doesn't look that reactionary to me, but perhaps it is. Reactionary fat is oftentimes really echogenic fat. This looks pretty much isoechoic to everything else around it. Or it's just plain fat. But it's reactionary because that Crohn's is so inflammatory that it inflames your surrounding fat, or it can inflame around surrounding fat. Appendicitis, adults can get this, but we're going to talk about this. It's worth going over. I think we've already mentioned it, but gosh, I don't expect you guys to remember too much about this. Appendicitis, McBurney's point. This is where you're going to start your exam, at McBurney's point, or at least in this general area. I actually start my exam up here and I work my way down through McBurney's point. That is fine. McBurney's point is 2/3 of the distance from the umbilicus to the superior iliac spine. What's that? Well, when you feel your hip bone on your anterior hip bone, that's the spine. 2/3 from, or you could turn around and say 1/3 from the spine to the umbilicus. But in any case, that's where most people's appendices are. Most people's. Some people have an appendix all the way up here, some of it's down here, some of it's more midline, some of it's retrocecal, like behind, and even if it's retrocecal, it's actually in the retroperitoneum, which makes it pretty much impossible for us to see. But it could be in any of those other places, but most people are right here. Now what I do, let's see, is this a kind of right lower? Okay, so this is a transverse view. They're using an L12. That's a pretty, that's a fairly high frequency transducer, but this is a skinny little kid, looks like. They've increased the size of their view here, and they go to the cecum. Cecum's the one that's filled with gas all the time, so that's how we know it's the cecum, and it's also the lowest point over here. So what we look for is, you know, we have this gas structure over here. It's all, okay, it doesn't quite look like that when it comes across and then down, of course. But here's our colon. Colon's usually, not always, but usually filled with gas. And so what I do is I go transverse up here, where I know I'm way up on the colon, and I work my way just straight down, following this gas. And here it is, that's following that gas until suddenly I'm out of gas. Sounds funny, but suddenly I get to the end of the gas. I know I just went off the end of the colon, end of the cecum. And that's where we're going to find, let's use red, that's where we're going to find this guy coming off. Oh, this one's got something in it too. I didn't notice that before, because this is a pretty normal looking, that's a pretty normal looking appendix. It's laying, on most of the cases, it's laying over the psoas muscle. It could be laying over the artery or artery, really, the iliac artery. That's not the iliac artery, though, is it? Iliac artery is probably over here. That, just by the shape of it, that looks like a vein. Anyway, let's get rid of some of our. This is pretty normal looking. That's a, you see multiple layer walls here, but thin, really thin, until, look at this, we get a little something going on here with shadowing. Now your book says that, and I'm not doubting the book, don't get me wrong. Your book says that an appendicolith, that is a stone, an appendicolith, kind of like cholelithiasis, but it's in the appendix. Anyway, there's a it's very echogenic, and there's definitely some shadowing, but it's kind of dirty shadowing, isn't it? It's not really a thick shadow. Well, in any case, I need more evidence, but in any case, an appendicolith, most people would say that the presence of an appendicolith is guaranteed appendicitis as well. Your book begs to differ. It says that an appendicolith can exist without appendicitis as well. But perhaps the happy medium on those two opposing views is that an appendicolith will eventually lead to appendicitis. Typical location, yeah, so it's sitting there. Here's another typical location. This is this one here is laying over the artery. So that's the iliac artery. And a blind ending pouch. Okay, here's the thing. Here's what makes life a little bit difficult for us. This looks like a blind ending pouch up here. Why isn't that the appendix? Well, when we look at this, now this is a pretty obvious looking appendix. That's just a beautiful picture. But when we're looking for the appendix, what we have to do is really prove, is this truly blind ending? Or is it simply a turn and we're not seeing the turn? That's what's happening up here. We have the ilium is coming through and then it's turning. It's making a sharp turn. We're not seeing it, so it looks like a blind end. But during live examination, you'll be able to know the difference. I grabbed one image. God, tell me I'm recording. Yes, thank God. All right. I've got one image over here of a gangrenous appy with a stone. So there's an appendicolith right here. And once again, that's not really shadowing all that much. So, there you go. I guess it's a, anyway. And why is this one gangrenous? Well, you don't see the color box, but you can see little splits of color here. Normally, appendicitis is like, there's color all over the place because it's super inflamed. Inflammation brings blood flow. This one barely has any blood flow at all. So it was, and I'm sure after surgery, they said, yes, it was gangrenous. It was basically dead. And so there's very little blood flow in here because it's no longer living tissue. Has some, literally crap in it. But actually, probably not fecal material as much as more gangrenous dead material sloughing off. So appy does not stand for AP diameter. It stands for appendicitis. But so we would call them out in the field. We just say it's an appy. But if the AP diameter is greater than 6 millimeters, let's go back up here real quickly. Just get away from me. All right, it's not exactly AP, but then again, you know, the direction's like that. So if that's greater than 6 millimeters, it's suggestive of appendicitis. Definitely millimeters, not centimeters this time. If it's non-compressible, so when you push down, if it doesn't squeeze or squeezes very little, in other words, you know, you have let's get back to black. You have one image, and you do a dual screen, and one image like this, and you have this suspected appendicitis here, and then the next image you push down, and it barely squeezes out. That's non-compressible. By the way, I should add, when you push down on this, the patient won't be, it's not going to feel good. But they're not going to be in too terrible amount of pain. It's when you release. So when you release, let's add something here. Rebound tenderness. Rebound tenderness means that when you, after pushing down, you suddenly release, and especially if you suddenly release rather than gradually release pressure, then they're in horrible pain. That's an indication of appendicitis. So they have rebound tenderness. Periappendiceal fat can be, you see the fat around the, whoops. I don't need that on right now. The fat around the appendix is inflamed, so more echogenic than normal fat. Oh, I thought I wrote something else. Periappendiceal fat, and let's do this. I'm going to add fluid. So if we have little areas of, well, let's have completely surrounded in fat, so I'll put the fluid over here. But just basically a tiny amount of ascites, only around here, or maybe a little more closer to the, you see just a tiny amount of fluid in that area. That's an indication. Now the problem we have is women, women of childbearing age, oftentimes get fluid in their pelvis because of cysts. So then you do have to be careful with that. Women are actually, of course, now we're talking about pediatrics, but let's say an older ped might be misdiagnosed as having maybe her first ovarian cyst, because it is kind of the pains in the same area, and if the appendix is not well seen, they might say cyst. Or if the appendix has perforated, in other words, broken open, that makes diagnosis difficult, because now the appendix is no longer 6 millimeters wide because it's been perforated and kind of squeezed out contents and everything. And now there's a little bit of fluid in the area, and actually it could possibly look like fluid from an ovarian cyst. The ovary is only a couple centimeters away from the appendix in many cases. And this word here is hyperemic, increased blood flow. Ooh. Oh, wow. We're done. We're done, except for just lymphadenopathy. I just want to make a couple of, just note that lymphadenopathy in the abdomen, yes, we could see it in adults, but we oftentimes see it in children. And so, here we have lymph node, and you could see, let's see, I think that's a lymph node, and muscle up here, some intestines here. But you can see these are not only enlarged, but where's the hilum? This one, I guess, barely has a little bit of a hilum there. No hilum, so something's going on. Here is a sagittal view. This guy here, well, this could be the renal vein. Probably it's in there. It's an exact spot of the renal vein. That could be adenopathy there though. But certainly here and here and here. So, you know, right in the mesenteric area, we have our celiac trunk, our SMA coming along here. By the way, right here is a little bit of the pancreas, which means above it has to be stomach. What is filling that stomach? That's, I don't know what's in that stomach. Maybe that's the reason for the lymphadenopathy. There's something going on there. Let's see what time is it. It's 10:16. I could have done a little bit more today. Okay. Well, so let me just quickly flick through. I'm not going to do any more. Oh. False alarm. Gosh, I'm so glad I what happened here? We didn't talk about that. All right, what I'll do is after we talk about this, I'm going to pause it real quick, make sure there's nothing else. I guess I'm a little bit out of the way here. Hirschsprung's disease is where are you? Hirschsprung's disease. This is a lack of innervation. In other words, a lack of nerves going to the intestines. There's actually nerves, ganglions within the intestines that kind of self-regulate their own peristalsis, which is kind of cool. So your brain doesn't have to constantly tell your intestines to go through peristalsis. They kind of figure it out on their own through, you know, they say, oh, there's food. I got food. I better do some peristalsis. That all works on its own. So these innervations are kind of self-controlling. But if there's a lack of these ganglions, there's lack of innervation in the intestines, that's going to cause a lack of peristalsis. So aperistalsis or aperistolic. Usually the large intestine, usually the rectosigmoid colon. And that could form something called megacolon, where because feces, they go through all the intestines just fine, and then they get stuck. And so this person's always going to have an issue with constant constipation because they don't, the very end of their route, at the very end of their GI is simply paralyzed. And so the feces gets to it and has a really hard time being forced all the way through. We actually see this in utero, sometimes in megacolon in utero, although a little less common because they're typically not pooping in utero. But Hirschsprung's can be diagnosed there. Actually, I'll just quickly, the pictures there. You've got to be kidding me. Okay, I did. I missed that section, an entire section. This is what happens when I go entirely from the page here. We already talked about sclerosing and biliary, but we did not. Oh, we did. I got my little drawings here. We talked about that yesterday. Okay. Okay. Intussusception, we spoke about that. That is fun. Crohn's disease, API, lymphadenopathy. Okay. Okay. Now, guys, we are done. I will see half of you today. And well, let's see. I have a little 10:20. Good. I have some time. I will going to find a couple of good videos, and I will post those as well. And I strongly suggest you go through them. All right, guys. Adios.